Hey guys, Marshall with PhysioU, and I'm here at the teaching table. And this week, I'm here with, again, Chris and Cam, two DPT students who are going to ask some questions, and we're going to talk about the follow-up, right? So you've done your eval, patient comes back for visit 2. What do you do, right? And the idea is, big picture is how do you be efficient getting to a treatment? That's kind of the big goal, right? How do we make sure we can get to this objective, get to the objective, stuff we need to look at to treat, and not re-evaluate every single time they come back in. All right, so some of the key questions we want to know is, hey, how are you, right? How are you? Are you better? Are you worse? And then all that good information we gathered in the eval, remember we said make it measurable, make it specific. It's like, hey, that's why we gathered it specifically, so we can then say, hey, so how's stairs, right? Last time you mentioned it was a 4 out of 10 pain after that whole flight of stairs. How are stairs this week, right? And why are we asking those questions, right? The big picture is I want to know, are we on the right track? Is he better? Is he worse? Did we help them? Did we not help them? It lets us know how to go forth. Some of the other questions we want to talk about is like, well, the thing that we did offer them, how's that going? So if it's home exercise program or if it's an educational thing, like how the intervention we provided, how is it, right? So we want to get, how are you big picture, right? Did anything change as far as your specific ags, right? And then let's look at HEP, right? Or whatever it is that we gave them, are they on the right track? Is it painful? What's any limitations to them doing it? Like, really, in a 30-minute return visit, like no more than 5 minutes should be spent on subjective if everything's kind of going according to plan. If someone comes back and everything's significantly worse and pain locations changed, a little different, we may have to ask different questions or more follow-up questions. So, as we like to do it, what are some kind of problems you guys have seen, or difficulties, maybe not even problems, but challenges in the clinic when we talk about the return visit?
I think, the first time this happens to all of us, especially us going out first time in the clinic, is that first patient that comes back that didn't get better. We kind of have like did I do anything wrong? And then you kind of go back, well, what, did I mess up? Did I give them the wrong HEP? Because then, that kind of interrupts the buy-in that patient might have, and maybe getting that third visit.
Okay, that's a good question. Nice thing is it's going to happen more as you go on. That won't bother you as much, right? It happens more than we'd like it to, that they come back. And then the idea is, like you said, 2 parts. Well, 1, why did they not get better, right? And then 2, how do we make sure we keep the buy-in? So kind of we'll try to answer both of those. The question about like why didn't they get better? Did we choose something wrong, right? So the nice thing is if you had from your eval, like, hey, this was the impairment I was working on, right? So for example, let's say we were working on quad length, quad flexibility, right? We have a very measured angle for that, right? The nice thing is, right, it's objective, it's measured. So, hey, if you've been stretching, I've been stretching 3-4 times a day. Okay, great. If I check that quad angle and it's better, it's 10 degrees better, and his symptoms are no better, right? Still hurts the same with the stairs, then I could say, hey, maybe that impairment wasn't the right impairment, right? So to keep buying, I'd be like, hey, you did exactly what I asked you, right? Patient was right, right? You were at 110 last time, now you're at 120 degrees of prone knee bend. It's great. It just tells us that even though you're 10 degrees more flexible, that necessarily wasn't the thing. So let's find out, is there another impairment to address? On the flip side, let's say you measure that angle and it's still at 110, it didn't change, right? So then I go, okay, so now the impairment's still not the problem, still there, right? Was the patient doing what they were supposed to be doing, right? It's like, hey, let's go over that exercise again real quick and have them demonstrate. Before you tell them what to do, this is something I learned. I used to be like, hey, let's do that stretch. Come on, lay on your stomach, here's a belt, pull it to your butt. And I pretty much do it for them. Now it's like, okay, so show me what you've been doing. And they come up and they show you something crazy. And it's like, oh, that's, okay, I don't want to blame the patient, okay. Let's see if we can modify that a little bit differently. You change it completely because what they showed you was not a quad stretch, right? It's like, okay, let's change that, let's modify that to make sure you really feel it in your quad muscle. And then you go over it again. So then you say, man, the problem wasn't the impairment, the problem wasn't the intervention, it was how I got them to understand what they're trying to do. So I'm going to make sure, this visit, I'm going to make sure we're going to do that 3 or 4 times, having them set it up, and then tell me where they feel it, right? Make sure that they understand. So when they go home, they understand, like, this is the goal, right? Feel the stretch. But again, the buy-in part comes in having confidence in yourself. If you're like, oh man, I don't know why you're not better, versus being like, hey, you know, even if you don't get better, we work on this, there's other things we can work on to help improve this, right? This was just the one we wanted to tackle first. If it's strength, it's easy, right? Oh, you remember, we don't get stronger in a day, we don't get stronger in a week, right? So doing it right, just kind of keep going with it, right? It takes 6 to 8 weeks to get stronger, right? You can kind of, as long as you come off like, hey, you're confident, you know what you're talking about, use a little bit of research to back it up with evidence-based practice, you can keep the rapport. Good question.
I have a question regarding, say you haven't seen this patient for 4 or 6 weeks.
Okay.
You had a plan that they would do this for the 4 or 6 weeks. You don't really remember this patient when you read their name on the chart.
Yeah.
What are the key themes you're looking at from your last note in order for this follow-up to go efficient and in a timely manner?
Yeah, the goal is, unless the goal was to do a reevaluation, ideally we don't want to reevaluate every time they come in, right? We want to kind of get to the nuts and bolts of it. So yeah, I'm going to look at, hey, do they have their body chart? What was it, right? So I want to know, has it changed? So I got to know where it was. I want to know about their ag. What was their primary ag? Because I want to know, is it different? So stairs, 6 of them, 10 of them, whatever it is. So I want to know those from the chart. Like, hey, what was your body chart? What was your ag? I want to know what your primary impairment was, right? I want to know your asterisk sign. So, hey, stand up. Hey, go ahead. Last time you did 4 jumps and it bothered you. Let's do your 4 jumps, right? Show me. And then, okay, we were working a lot on glute med strength. Get on the table. Let's get our handheld dynamometer, right? And test it. Right? So those would be the key things. So I want to know, pretty much it's almost as if you walked out of the room after your eval to go wash your hands, and you walked back in and be like, hey, what's changed since I left? Right? What are those key things? In my notes, I bold them, right? Because yeah, you have all these things in your notes. I have these ones bolded. So when I'm chart reviewing, I can just see the bolded stuff.
Got it.
At the end, you normally have a plan. So I already know, because when I'm typing my note up, I'm never going to think about that patient more than probably in that moment. So when I'm reading my note, at the end it says future visits, it's like, hey, ask about stairs, recheck glute med strength and deep squat, and if we're doing better, progress to single limb balance exercises or something. I already have it planned out, or like a quick little outcome, or outline, I guess I would say.
Nice.
Yeah.
You have one more?
Oh, I have another one with, let's say they come back with different symptoms.
Okay.
What should we do? Let's say it's shoulder pain in the front and they're lifting up and now they have shoulder pain in the back. So are you gonna clear out the front and then go to the back, or what are you gonna do?
So I wouldn't clear out the front. I guess it depends what your definition of clear is. I would retest my asterisk sign. So if
Okay.
their asterisk sign was, hey, reach into the cupboard, or it was abduction overpressure, whatever it is that brought on their pain, that I bolded and I was using that as my reassessment every time, right? That's my asterisk sign. I would recheck that to see if it still brought on the front of the shoulder pain, right? And if it didn't, I'd be like, okay, the thing we were working on is better. This other thing, when do you get it, right? Now, if I lift the arm above and it hurts in the backside, but it's still the same motion, I'm gonna probably just continue on, because we know location of pain can change, whether it's the front, the side, the back. A lot of times it can still be the same structure, just having different spots. Like people always say, it's not my shoulder, it's my arm that hurts. And you're like, well, tell them about your shoulder pain. It's not my shoulder. Okay, this is a common place that refers from the shoulder, right? We kind of know that areas are different in everybody. So I use more of the asterisk sign that brings on their pain or their limitation than I do actually the location.
Got it.
Yeah, that's a good question. I think one of the biggest things with the follow-up visit I want to make sure that we get is reassessments, right? I tell people it's like you did your eval, you walked out of the room, right? You're coming back in. It's just almost like you're continuing on for everything. So hey, let me recheck that one thing that I was using as my asterisk. Let me recheck the thing we treated. I want to know if it's any better, right? I use the analogy sometimes. It's like you're closing your eyes and you're painting a picture, right? That's you treating. Don't you want to know if how it looks, right? Don't you want to open your eyes, take the blindfold off and see what it looks like? That's you rechecking your work, right? Do you think that helps with buy-in?
Absolutely.
Yeah. If it doesn't get any better, do you think that helps with your clinical reasoning? Yeah. Sometimes that doesn't help with buy-in if it doesn't get any better, but you have to be able to say, hey, if it made it worse, I'm not going to send you home with that, right? So you kind of have to. It's important to realize you recheck. So I'm always rechecking. In a visit, if I've done 2 or 3 different treatments, I start to stack treatments because I've seen them a couple times. I'm still reassessing after treatments to see which one made more of a change. Because you get the patients, I always like to get the patient's feedback too, like, hey, what do you think made more of a difference? They can help you with your clinical reasoning. When patients come back from subjective and they're better, it's like, hey, why do you think you're better? Right? I want to get patients' perspectives because you used to always think it was you, right? Hey, I'm feeling better, yeah. Okay, well, how much better are you? Right? Oh, I'm like 60% better. That's awesome. Yes, that exercise, totally on par. I nailed it. Right? Give yourself a pat in the back. And then you realize he didn't do the exercise one time. He doesn't even, what he showed you was him not anything near. It's like, what the heck? How are you any better? Right? So why do you think you're better? Oh man, my grandma gave me this new cream I've been rubbing on my knee. Gotcha. So wasn't your exercise at all. Take that pat away, right? So it's you kind of start to get these patients' perspectives to realize how can it help you figure out your reasoning and kind of which path you take. Any other questions or?
I think you answered them all. Thank you.
Okay, cool. All right, well, thanks guys. Thanks for joining us with PhysioU and the teaching table. Make sure to check out PhysioU.com and follow us at PhysioU social media stuff.
Cool.
Take care.